Under her leadership, the IWHL has grown in size and stature and has earned its place as one of the top priorities of the medical school at Drexel. And she's now working on constructing a new building that will house the Institute and its core programs. Very importantly, since starting this institute in 2002, she launched the Woman One Award and Scholarship Fund, which has raised $1.5 million in medical tuition scholarships for minority women. And for that, you get all of our accolades. She is also very much involved with the new initiative that we heard about, the Vision 2020. And she's put together a terrific panel, and we're going to learn a great deal from them this morning.
Thank you very much, Jackie. And this is a pleasure for me on several levels. But I'll just add a couple of things to your introduction, which is, first of all, we moved into our new building in December, so we now have a new permanent home for the Institute for Women's Health and Leadership, and in particular, we raised additional money to bring the historic archives and special collections on women in medicine, which go back 160 years. We brought that with us to the new medical school. The other thing I just want to mention parenthetically is that the Woman One program, which is 8 years old this year, our first honoree was Estelle Richman, who is sitting right here. And she helped us get that program off the ground. And in fact, her best friend from childhood came up from Washington to speak for her that night, and that was Dr. Vivian Penn, who many of you heard yesterday morning, who is wonderful and a real leader in women's health. But I want to start by saying a word of congratulations and thanks to my good friend, Dr. Dean Afaf Malise, who is a colleague in women's health, but she's also a special friend. And it is a real pleasure to work with her on so many of the initiatives that we're passionate about. And I really want to congratulate her on this wonderful conference. I mean, it's just been fabulous. So we should all applaud Dr. Malise. I also want to say a few words about this wonderful panel and about the format, because we're going to do things a little differently than they have been done since we are the last panel, and we agreed among ourselves that we would be rather spontaneous about this because we want to build on some of the things that we have heard at this conference over the last 3 days, and we want to envision the world that we would all like women to live in the year 2020. That's what Vision 2020 is about, and that's why you see the overall goal statement. The vision is for women to be in leadership roles in health policy and planning, urban planning, all the things that we're concerned about to improve the quality of life of women, to be in leadership roles by the year 2020, so that we know that will then affect the outcomes in terms of women's health around the world. Vision 2020, I just want to say, is a project that is out of the Institute for Women's Health and Leadership that is based on our 160-year history as the first medical school for women in the world. But it's also focused on the year 2020 because that is the 100th anniversary of American women's voting rights. And so we feel that the opportunity to plan for the decade ahead and to get our own house in order in this nation, and then to move that conversation beyond in the decade between 2010 and 2020, to move it to a global level, which is where I hope all of you will be participants. That opportunity is a very exciting one. So when I talked with each of the panelists, we agreed that what we wanted to do was to identify some of the key issues for women's health. And of course, in urban settings is the theme of the conference, but I think we're talking about that and beyond. And to imagine the world that we would like to see in the year 2020, recognizing that women's leadership is directly connected to those outcomes. And that is really a core value of the Institute for Women's Health and Leadership. It's also something that we firmly believe. And that leads me to introduce the panelists, and I'm going to introduce them one at a time. Again, sort of unusual process here. And I'm going to introduce them alphabetically, starting with Dr. Eliana Amaral, who is sitting farthest from me. Dr. Amaral is an MD. She is an obstetrician gynecologist, and she is director of the maternity unit at the Center on Integral Assistance to Women's Health at the State University of Campinas, is that right? In Brazil. And Dr. Amaral is also a co-director of FAMER in Brazil, which is an international program that trains women and men in the health professions to take leadership roles. And that's actually how Dr. Amaral and I connected, because one of our faculty at the Institute who founded the Executive Leadership in Academic Medicine program that's run out of Drexel was a co-founder of FAMER and works with Dr. Amaral. So I'm going to ask, Dr. Amaral also does research that's links academia and communities, brings learnings to community settings so that the two are not different. So I'm going to ask Dr. Amaral to tell us how women's health advocates in Brazil have influenced government policy and what that policy looks like now that we can learn from.
Well, I think all the women's movement in Brazil was very intense in the 70s, and in Latin America in total, this movement was really totally related to the political moment, what means we had a lot of dictatorship, and so the situation of the power, political power, was very strong, and helped in a way the women be together to work on some direction that is recognized, let's say, by all the society, independent of being women's issues or men's issues. So what happened is that after that, in Brazil, during the 80s, it was created a National Council on Women's Rights. And so it's very active since then. Recently, in 2003, the president, in the first day that was when he signed his position as a president, at the same time, he established a new secretariat as a level of ministry that is the Secretariat on for political issues and women. And what is the Secretariat for? To make the link between, transversally, the link between the diverse programs into the Ministry of Health. So the women's movement in Brazil, since the beginning, was very close to the government in such a way that it was able to make their point very clearly. In the middle of that, there was a program called PAISME, what for us means Integral Assistance to Women's Health. So my institution, in fact, was a kind of the testing, the pilot place to test the idea of integral assistance to women's health. It was created in 1987, and I entered this institution exactly at that time. I came from another medical school. I'm not originally from this school, Unicamp. And what represents that? Represents that there was a movement in Brazil to create, at the level of the Ministry of Health, an integrated program on women's health, including family planning, but not only, because during the past, there were only two focus, antenatal care or family planning in a kind of sense of controlling. And so what happened is that this PAISME was a discussion, a very open discussion with feminists actively participating, plus academics that were sympathetic or were more prone to understand these problems, putting together this program. So the program turned to be official after the CAISME, the institution where I come from, was launched. So the program came in 1991. And after that, the Ministry of Health has worked in this direction on trying the better than we can in our universal health system that is free for everybody, and there is a lot to discuss about that, with a very active role of the communities, including women, to make this program, the access to care for women, all the kind of access that they need, as much available as possible from the primary level of care. And I think what is very strong in Brazil is the activism around the primary level of care. And this activism has a very intense role of women. So I think it's embedded in the way the health system was came up with our constitution in 88.
Well, it's a great model and an example that we need to learn from, which is exactly why I wanted you to describe it. And just tell me one thing. What was the time lag between the energy and organization of the community advocates, activists, and the government responding with an official position?
Well, if you think about the 70s as the active time where things were more intense and there was the sanitary movement in Brazil, what means that the people from the public health were making a very strong effort to put the new system in place, so the things came together, and they went through the 70s. So actions began to appear in the 80s, late 80s. So if you ask me what's the lag time, maybe 10, 15 years to things really to happen.
I'll tell you just parenthetically why I'm interested in that. When I worked for the Department of Health and Human Services, the Violence Against Women Act had just been signed into law by President Clinton, and I had been working with domestic violence organizations in Philadelphia 20 years earlier, and I heard the exact same conversations taking place at the policy level, by which time there was funding for hotlines and other kinds of support. And it's just interesting to me, one of the things I think we need to do as part of our vision is to close that gap in terms of timing. So that's just a little editorial comment. I'm going to introduce now Estelle Richman, who is somebody who's known to people in Philadelphia. Estelle has been a public service leader for many years at both the local, state, and now federal levels. She was the Commissioner of Health in Philadelphia when I first came to know her. Then she became the City Managing Director. She is famous for her leadership on behavioral health issues. I think that's an area that we'll want to come back and talk about. But she then went to Harrisburg to be the Secretary for the Department of Public Welfare in the Rendell administration, and most recently has gone to Washington to be the Chief Operating Officer for the Department of Housing and Urban Development, which is very appropriate to our conversation here today. Estelle told me that in that role, she's directing traffic within this large federal agency, which sounds like a pretty horrible job. But I would like to ask Estelle to describe for us the link between housing and women's health.
There are so many links between urban housing and urban development and health. I think I have been able to figure out over the years that two of the most critical factors that we need to be concerned about are both food and housing. They come first in so many ways. If people are wondering how to feed their family, what to feed their family, and if there's going to be food available anywhere in the world, it becomes the first thing they worry about. The second one actually is housing. People on the street first want to get into something stable. Family stabilization is so critical, and both link back to healthcare. I think I saw time after time, both in Philadelphia and throughout the state, is that our worst health outcomes are for people who are living on the street, people who are homeless, people who have unstable living arrangements. First need that stabilization. The number of babies we lost sometimes in shelter, the number of children who, because of the way they move around, and it's just access overall. Many of these folks have insurance. They have Medicaid, so it's not always the lack of insurance, it's lack of being able to get to the healthcare provider. It's lack of being able to have the stability of being able to work your healthcare provider. But HUD right now is really focused on urban development. I think one of the things we've begun to realize over the years is there's been a lot of attention paid to housing, and housing is critical, important, but housing lies within communities, housing lies within neighborhoods, and it's not just the house. It's part of a community and neighborhood. It's having accessibility to clinics. And part of what we will see in the future is hoping to have more clinics within these neighborhoods so healthcare is accessible. People often go to what's closest. What's closest in our community frequently is an emergency room. How do we get our clinics? How do we get our federally qualified health centers? How do we get our doctor's offices close to our largest communities? How do we begin to focus on childcare? How do we make sure that those childcare opportunities, we want people to have opportunity to move to work. We want people to be able to take part in their wider community. Therefore, we need good, safe, affordable. We need our education system. You know, one of the things that, one of the books I've enjoyed over the last several years is 3 Cups of Tea. I hope people have read that. But one of the things it brings forward so strongly, if you're going to change culture, you're going to educate the women in a community and society. You're going to be able to help them understand the importance of food choices, the importance of housing choices, the importance of health choices. And as we educate women throughout the world, we're beginning to change what each future generation can contribute. I think that as the federal government begins to understand more about communities, community development, our urban cities, our rural areas, what we will come back to is the number of women-led households, the importance of women in making these and helping make these decisions and setting the tone for these decisions, but truly understanding the interaction between healthcare, housing, food, and the women who control these factors throughout the world.
Thank you, and that is very, very appropriate to the theme of urban areas. And I think that the federal government, the Department of Housing and Urban Development, is extremely lucky to have Estelle now in this role because she has got the direct experience of working at the local and state levels. Our third panelist is Dr. Nancy Woods, who some of you were introduced to yesterday. Dr. Woods is a professor in the Department of Family and Child Nursing and Dean Emerita of the University of Washington School of Nursing. She is a women's health researcher who has particularly worked on symptoms of the menstrual cycle and menopausal transitions. And I wanted to get to the topic of older women. We all know about the demographic trends, and I feel as though we don't have enough discussions about what that growing population of women over 65, not only in the United States but around the world, what that means for women's health and women's health care and quality of life. So rather than thinking about it as an intergenerational topic, which was the discussion in the prior panel, I want to ask Dr. Woods, and by the way, we both discovered that our parents lived into their 90s, so we have seen firsthand some of the issues that we're all going to be facing at some point, probably. So what is the impact of the aging women's population on women's health? What do we need to be thinking about to address some of these issues?
It's a great question, and I'm pleased to try to grapple with it. I sit here to locate myself as a 63-year-old. I'm the oldest of the baby boomer generation. I am not thinking about being at all retiring, but am trying to imagine the next stage in my own work, but also realizing that I am the oldest of this very large portion of the population, which will age over the next few decades and require different kinds of adaptations across the lifespan and across our lives. So I find myself thinking about that a great deal, but I also find myself thinking about a notion that we have begun writing about and discussing inside the Academy, but I think we've heard articulated beautifully in this conference, and that's the notion of intersectionalities, or, as Vivian Pinn talked about it yesterday, disaggregating the data. So I cannot be here as a representative for all older women, although I have gray hair and some of the markings of being an older woman. But the importance of thinking about who I am and who you are very specifically will help us think about what policy needs to look like to help us as we age. So let me dig into that a little bit more deeply. I have had the good fortune to have had access to education over the course of my lifespan. I've had the good fortune to have access to employment and a continuing income. I have not had the battles that some of my colleagues have had facing discrimination because of my ethnicity, though on occasion I suppose I could say because of my gender. But I have had a privileged existence, and I have had the benefit of working with students who have helped me think about a notion called white privilege and what it is that puts us in a position sometimes to not see problems in the health and aging of many groups of older women in our population. I would say that as we begin to think about aging and aging women's health, and particularly aging women in cities, that it would be advisable for us to begin to consider who these varying populations of aging women are. What is their location? Not just in terms of their neighborhood or their census tract, though that's very important as we've heard in our discussions, but their location socially, their location with respect to economics, their location with respect to their educational backgrounds. As we begin to look at services for this burgeoning population of women, it would be very tempting from the public health approach in which I have been schooled to think about aging women as a whole, as an aggregate. And yet what we heard Vivian saying yesterday and what our colleagues to the north in Canada are beginning to write about is the importance of understanding specific subgroups of our population. There's a wonderful model for this that I've come to learn about since I've been visiting the University of Pennsylvania, and that's the LIFE program in this community that has created a program that helps urban dwelling, particularly African American people who do not have access to many financial resources, maintain their capacity to live in their homes, maintain the capacity of the families who care for them to continue to be gainfully employed so that they can support those older adults, and to continue to provide opportunities and avenues for engagement for the older adults in the care of the life system. The ability to come to a safe space, we heard this discussed in many of the presentations at this meeting, and the opportunity to engage with people who are not only from their own community or their own age group, but to do the intergenerational conversation. So if I had to think about what would be high on the list of my priorities as an academic thinking about the challenges of not only my own aging, but the aging of my sisters across the world, I would be thinking, first of all, about the importance of the safety of the spaces that they occupy. Secondly, about the ability to remain engaged and viable as elders in a community with much to contribute. Third, I would think about access to a set of services, and by this I'm not restricting the set of services we need to the traditional healthcare services, but thinking about the kinds of services that are part and parcel of our everyday life in communities, whether that might be access to hygiene support services or whether that might be access to services that bring in a source of stimulation in our lives. So I think I would start there by asking which groups of older women, very specifically, and what is it that that specific group of older women would articulate as high on their priority list, and really digging into, and as Vivian would have said, disaggregating the data. But for those of you who want to learn more about intersectionalities, I would recommend looking at the Canadian view of how one does intersectional work, both in understanding health, but building from that understanding to analyzing policy and creating new policy to support that happening. Thank you.
It's interesting. I was going to ask Dr. Woods about the word intersectionality, which she used in an email to me, and I thought, I wonder if that's in the dictionary. I don't know. It's easy to understand what it means. That's great.
It came into my vocabulary many years ago, probably more than 20 years ago now, by learning from Patricia Hill Collins, who wrote about Black feminist theory and thought, and who emphasized the real importance of understanding the populations, not just as an aggregate, but the specific groups within that population for whom we would provide health care or think about policy.
Thank you. I'm going to go back to Dr. Amaral and ask her to comment on that in terms of older women's issues and the whole healthcare access, since we've got new legislation in the United States that is as yet untested in terms of exactly how it's going to work in providing insurance coverage for so many millions who don't have it. Brazil has that coverage. How has it impacted women's health? And any comments you would have on the older women theme, and then I'll ask Estelle the same question.
Yeah. Well, Brazil, sometimes people think that Brazil is less urban than it is.
And what?
Brazil is really urban.
Oh.
Anyway, so even if you go to the north, where should be less, 80% of the population lives in the urban area. So in the south where I live, it's 92% what is urban. And comes with this urban thing plus education plus everything. Brazil in 2025 will have more people from 65 on than the young people. So we are in the same position, in the same situation, some heterogeneity along the country, but it's very similar. So our health system does provide traditionally antenatal care, family planning with, of course, not everything is perfect, but it's there. It's there in places in Amazon where you can never imagine, boat hours and hours through the river to get. So there is this capillarity of the system at this point. But approaching the problem of the elderly is something else in Brazil now. We don't even have a big generation of professionals trained for that. So we do have to train a cohort of professionals in every area and field to understand the problem of the aging of the population. So this is very rapid in Brazil. The decline of the fertility was also very rapid. We are 1.9 now for the country as a whole. And the difference is from 1.6 to 2.3. So even in northeast or north of the country where we say that there's the wealth is in the south, but it's the same. So we are moving very fast. So to face these new challenges, we have to be prepared, and we are now in the point of how can we do. I don't think that we do have the answer at this point. What I mean, we don't have the energy put together to go for it. And I think there's a very important point made on the heterogeneity of any group, because when we talk about one group, we put some label, and you understand that they are the same. And I will bring here a very personal experience in my professional life. besides the personal that will take longer. So let's go to the professional. I work since the early 90s. I work with HIV women. And I started working in 94, and my master thesis was about prevalence of HIV among pregnant women in the city of Campinas. It was a populational study on that. So pregnancy was the focus. Immediately after that, I started to worry about their gynecological problems. So I established a clinic to care for the gynecological problems. And in the last 5 years, I keep saying and telling people, please, we have to organize care for elderly and HIV, because this is a demand. Now, 1/3 of the population I take care regularly each week, they are 40 plus. So this is a big change on everything. So the kind of demands, we don't even have an idea what means. So the society is not structured to take care of the elderly. The change, you know better than me. Since we have women working hard, who is going to take care of the elderly? We don't have a culture that, accepts the housing outside the family. Mm-hmm. It's traditionally very, very difficult for our cultures to be accepted. So we are in the moment of transition in a very rapid way. So we have to run and organize ourselves. So the system in Brazil, we do have councils on the elderly in all levels of the country, municipality, because it is something else about the health system in Brazil. We are hierarchically organized. So the municipal level, the state level, and the federal level, but the guidelines, the consensus on how to do, they go spread around the country. So we do have councils of elderly, but the activism among the elderly to make their needs to be fulfilled, I think it's something that we have to learn very rapidly.
So again, as we're thinking about 2020, the year 2020, and our vision for what that world of possibility could look like, this is a very significant topic. And the issue of the caregiving for older parents or older people when we've got more and more women in the workforce is another theme that I think is tremendously important. So Estelle, talk to us about the government and the disaggregation of data and comment on all of these comments.
Well, I'm going to comment partly from being part of the Department of Public Welfare, where indeed life programs were one of our major themes. But we are in the process, I think, of redefining what aging means. As someone, while you were the first of the baby boomer generation, those of us born in 1943 are the first of the groups to change what Social Security retirement means. We're the first group that age 65 was not the retirement age. We're at the beginning of you had to be 66. As someone, my grandmother lived to be 109.
And she didn't like living with all those old
and
people.
She did not. And she lived totally independently until she was 105. And at that point, my mother moved her into an assisted living where she would not participate in the group meals because the people were too old. She was by far the oldest person there. But she still was very, very, very active. And it was only that where she was living, she was still frail, and everyone else was concerned for her safety, but she was perfectly fine. But I think she died in year 2000, born in 1890. But what it began to speak to is our world is changing. And when she died, I said, people will think at that point 109 was old. I think 109 for my granddaughter, who is 4, will be routine because we're changing. And in Pennsylvania and many of our states are part of that change. What we're seeing is a bimodal change, is that we're seeing a peak now around 85. That is very different from those of us who are 66. While we're considered elders and seniors, and people are sort of anxiously waiting for us to retire sometimes, and most of us are thinking, I think I can do one more thing. The reality is, where do we stop? Where does the younger generation come in? Our health issues are very different from the health issues that I think will become apparent at 85, but think of the health issues that kick in at 100. When your mind is still active and your body still wants to do new and exciting things. Our world hasn't adjusted to that yet. And I think the challenge to us will be, what are those issues and how do we think about them? And where will we go with them? The other reality as part of this is we are still tending to outlive men by somewhere around 7 years. You know, my pitch to men usually is now, go take care of yourself. And try to catch up with the women. But that puts us into a different framework also. Living arrangements, where we live, our choices to live, how do we choose and live with safety, become critical issues. It used to be when grandma had a stroke or got sick or fell, into the nursing home, sell the house, that's where she lived. We don't want that anymore. We don't want to be there. We don't want those decisions made. We want to recover back at home, and we want the health care to come and help support us. We want to age in place. We want the kind of housing that will make us feel safe in aging in place. We don't want to necessarily, this isn't true for everyone, but we want to basically still maintain our independence for as long as we possibly can, which means our housing, our health care, what we do. We aren't ready to say we're going to sit on that porch and rock. We want meaningful things to do. They may be of a volunteer nature. They may be going into the schools. It may be mentoring. It may be helping people. It may be that grandmother on that porch who watches the kids go back to school and forth every day, who has an awful lot to share with her community. It may be the person who just says, you know, I think that family over there may need some help, and know who to call and how to get it. But as our roles change, we still want to be an active part of our communities. And to that, our health becomes important, our neighborhoods become important, our communities become important, and our role in them will be just as important, although it will change. I'm not sure our world has caught up. We're still talking too widely. We still are thinking, people 65 and older are seniors and therefore are going to go to Florida or go to Arizona, and we aren't. We're still here. We plan to be here, folks, but we but we want to mentor now, and we want to tell you how I feel, and we want to be able to pave a new way for people to see living as 100. It's the old 80. That we're going to be here. Therefore, we really need to understand. I need to make one more plug. This past Wednesday, the government made good on the president's promise to open government, and every single major department published an open government page, and the focus plan, and those plans will be developed. The key to this is not for the advocacy groups and the watchdog groups within the Parkway, although the Beltway, although that's the way many people will see it. It really is to say to all of you, there's a way to get to information and data from the federal government, that you can go into a website now and pull out raw data, raw information. But more important than that, it's an opportunity to say, I want this data. I want to see it. And I want to see it broken down by women versus men. I want to see it broken down by areas of the country. I want to see it broken down by age groups. I really want to see how many women over 85 are in the various states or where they are. I want to see what are the kinds of diseases or the kinds of illnesses or the number of falls that people over 85 have. We also need from you is what is the best format to give you that data. My guess is a large number of women in this room, of people in this room, have computers. but I want to hear from the person who's living in one of my housing projects. I want to hear from someone who's receiving an FHA loan. I want to hear from folks who don't have computers. How do we get information to you? How do we hear your issue? We need you to hold us accountable for producing data and feeding it back to you in ways that work for you and are understandable. You know, one of the things someone said is, many people don't have computers, but a larger number have phones that text. Is there a way for us to get some of this key information for someone who's using a phone to text? And while maybe a senior my age, unfortunately I live on computers, may not be able to use a computer easily, there are computers in almost every assisted living facility I know of. And people are learning to use it. What kind of information can we answer for you? The Open Government Initiative is meant to reach out to all of the folks, not just the folks inside the Beltway. Any more information on that, we can give you the website, but my hope is that it made a greater bang outside of Washington.
It's a great concept, and if it works, it could really change the way government services are delivered if people really do engage. Dr. Woods, comments on all of what has gone before here?
Yes. Well, I'm struck by the open government progress, and we'll be very interested in tracking that. I think that I share with you your concern about the digital divide. I live in the city of Seattle, where we're a very wired community, but a few years ago I was involved in a project that tried to create a decision aid for women to use about how to promote healthy aging. This was for midlife women. And very early on in that project, which was to design a web-based decision aid that presupposed women had access to computers, I raised the question with the rest of our investigators about how could we help women who typically would not have access to that kind of information resource. And in the process of answering the question, of course, they said, well, why don't you go find out? Why don't you find out how, you know, women in these various communities and neighborhoods in Seattle access information and whether they can access information on the web. And I found myself doing a focus group in several neighborhoods, including one in Spanish and including one with women who were living at the YWCA in low-income housing. And as it turned out, in the very early focus groups, I discovered, to my delight, that the librarians in the city libraries were a wonderful conduit for health information, and that the women who were newly living in the Y or in other living environments for women who had literally come in off the streets had quickly discovered that if they went to the public library in their neighborhood, that working with the librarians there afforded them a quick access to the internet. And the only problem was that there was a time limit placed on how long they could use this particular computer. Nonetheless, it gave people access to a wealth of health information that they then shared with other women in their social networks. So I think that continuing to press for not only the use of the web, the internet as I've described it, but using text messaging, using some of the other new communication technologies is going to be very important. I was delighted when I went to Brazil several years ago to discover that many of the people I was working with had skipped over putting up telephone wires, and they just went to satellites, to use cell phones as a major form of communication. So I think our ability to think more cleverly about this, but then also to think about media that are sensitive to the particular subpopulations that we want to reach with health messages. So as I think about older groups of women, as I think about groups of women living in some of the neighborhoods in my own city, some of which have some health metrics that don't look like people are living in a wealthy country of the world, it occurs to me that we need to continue to stretch ourselves to think about how this particular policy or how this particular intervention is really going to work with that particular population. So the 100-year-olds are a great challenge for us. And at the same time realizing that the 100-year-olds are inhabiting a world where some of the stresses and strains on very young groups of women are very tough. And finding ways that we can create policies and create interventions that honor the needs of both of those age groups at the expense of neither would seem to be our next political challenge. So how do we provide the services that our aging population needs at the same time that we're not failing to attend to problems like unintended pregnancy, where we still, for example, have not met the 2010 goal of reducing from 50% of pregnancies being unintended to perhaps 30%, as was the goal. How do we simultaneously integrate policy positions that honor the 100-year-olds in our community and at the same time honor and support the needs of the very young and vulnerable women in our communities?
That is a perfect segue into the issue of the training and education that will be needed for healthcare professionals, for new ways of thinking about models of delivery. Again, I'm trying to focus us on the future, on the issues that we know are coming, and on the Vision 2020 concept, the project that we're working on, the kickoff conversation about women in leadership, an American conversation about women in leadership, will take place this fall at the National Constitution Center, and it will have women from all 50 states who are committed to go back to their communities and work on implementing the Declaration of Equality, which will be organized and overseen by Judge Midge Rendell. I just want to mention that because we are so delighted to have her involved. And sitting with her back there, I have to put another plug in, is the Vision 2020 project director, Kathy Omerod, who works with me at the Institute, and Rosemary Greco is my co-chair, so that's who we share with, another sharing with AFAF. But thinking about the new models of care, the new hugely increased numbers of people who will be coming into the healthcare system with insurance reform on the horizon, how do we train new generations and new professionals at different levels? How do we bridge the physician-nurse alliances and the community health centers and all those things? So I would like to throw that out as a question, and I'm going to go back to Dr. Amaral, who is working on the training of health professionals through the Famer Institute. And I think everybody should comment on that, because it feels that to get us to a goal of better care and outcomes, we really need to think about who those people are who are going to provide that care.
Yes. Again, what's going on in Brazil at this moment? In 2001, it was launched the new guidelines for the curriculums, okay, health professionals and other areas. And in the health professionals area, it's clear that the goal to be achieved is to have a professional that is competent to work into our reality, what I mean, our health system as it is. So there is a demand on these guidelines that the students must have contact and interact with the community and have contact with the health problems of the community since the very beginning of their training. So talking about medical school has 6 years in Brazil. There's no college, so it goes directly from when they finish the secondary school, they go directly to the medical school after a process of selection that we call vestibular, what's a big testing process. What we have in our curriculums now, and the government through the Ministry of Health, with a division that is related to human resources, they have grants to stimulate our health professionals schools to work together with the communities and the services themselves to make academy close to the service. So the students now have opportunities to understand, make, let's say, the diagnosis of the health problems of the population they are serving in the first year. Then they establish projects to interact with the community in the second year. Then in the third year, they got a better understanding of tools to understand collective health, than not individual health, like epidemiology, things in this direction, statistics. Then during the fourth year in my school, we have a special training, and it's a kind of model. The student will be in the same community from the beginning of the year through the end of the year. So one student in obstetrics and gynecology that goes to the community, to these primary health centers in the fourth year, will be able to take care of the pregnant women to the end. What's kind of difficult to happen in our curriculum in the way it is traditionally. So the change on the curriculum in Brazil is demanded by these guidelines that are national, but they represent, of course, a movement that is international and represent what in Brazil is deeply believed from these people, you know, in the reform. So everything, the stars are aligning. And this program, FIMER, that you just mentioned, by chance, had the goal of training professionals to be professionals trainers in health professions, with hoping to have an impact on the health of the population. So what happened? We are able to put together this program that is was born in Philadelphia, in Brazil, with the support from the Ministry of Health. In fact, in Brazil, it's a program supported by the Ministry of Health, because it's perfectly aligned with three different grant programs that they have in this direction. And I would comment that the last one, that is called Pet Saúde from Ministry of Health, they are giving money to make research. So they are supporting research, academia, and service in the primary level of care. So this kind of stimulus are helping the intellectuals to go from their silos and go through the community and work then. And the students, the more important piece, they now they have the opportunity to feel themselves how the advantage of being there, learning to be doctors or nurses or all health professionals, psychologists, social workers, etc. They do have the opportunity to see that. And not as it was, you get your diploma and then people say, look, the only job that you have for sure is in the public sector. And people would say, oh, so bad. So their image was very bad. Now they are there, they say, it's not that bad. It's really, really wonderful. So it's a changing situation, and it's going on again. 10, 15 years, I hope we can see more the impact of this change.
Great. Estelle?
My wish for 2020 would be that the concept of integration of healthcare teams, is no longer novel. It's something that we have done and have been continuing to do. That the struggle that we see periodically to move from a very strictly physician medical model to nurse practitioners to health teams becomes smooth and easy as opposed to a struggle. Here in Pennsylvania, we have really pushed. The governor's agenda has been to expand scope, to be able to see nurse practitioners as a dynamic medical team, a part of our medical environment. It's been able to say we need students whose ambition is to really become a good healthcare professional at any different levels of healthcare. that while we always need the physician, we need so many other levels of healthcare that are closer, that can be there with the community, that are creating those clinics. We have here nurse practitioner clinics that are some of the best in the world, and that we need to continue to make sure people see that. And that it's not a struggle, it's not an argument, it's not trying to persuade people that it's a good model. It is a good model. And we need our students who come in, we need our high school students, we need people who are beginning, our young folks who are saying, what do I be when I grow up? See team healthcare as where they want to be part of that. And that's both for our young women and our young men. I think we have moved from men become doctors, women become nurses, but we still have to do a better job of opening up our entire team. And that the team is not always headed by the highest degree, it's headed by the people who are closer to understanding the issues in the community. And our students and our curriculums are going to be that carries our message. I think for many of us, it's talking about it. It's getting people interested. It's making it exciting. And it's giving them and having them share our passion. So I'll stop with that.
Well, you know what I'm hearing from that too is the need for new definitions of leadership. It's really about the leader may not be the most obvious person with the most experience or the most number of letters after the or whatever. It may be the person who's got the best opportunity to build the collaboration and the team. So that's a very, very interesting concept. I want to ask Dr. Woods to comment, and then I know that all of you probably, not all of you, but many of you have questions or comments, and I would like to invite you to either write them down and we'll take them that way, or if you want to ask them orally, to just stand up and say who you are and ask your question. But let's have Dr. Woods comment first.
Well, I certainly it's a challenge to add to what you've said, but I'm going to try nonetheless. And that is, I think that part of what we need to envision for 2020 in the U.S. and perhaps elsewhere is a healthcare system that doesn't have the hospital at the core, but has the community at the core, and begins to elaborate outward what the services are that that particular community needs and desires, and realizes that that is a dynamic set of relationships. I loved and was inspired by Dr. Patel's comment about the enumerations in the slums, and I thought, gosh, you know, there is a fundamental place to start. Part of this, of course, is having the training in epidemiology that makes me think like that it is important to enumerate the population. But her process, as she was describing it, was not simply counting people as we would do in a census, but engaging people in articulating what was going on in their lives, what needs were being experienced in that household or family. And thinking about whether there are some clever ways, given that we now have the use of technology to monitor what is happening, the smart home concept of technology, what is happening in people's homes, so that we can provide a service if they have a fall and if they need assistance. Are there some other technologies? Can we use the cell phone technology? You really got me thinking about that. Can we use the everyday technologies that help people who are charged with the health of the community, and I'm not restricting that to professionals, to continue to do some of that enumeration in a way that continues to advise us on what are the health needs and challenges of the day and in the particular neighborhood. Can we also, in the interest of helping develop leadership in communities, can we engage young girls as well as their mothers in leadership challenges to begin to understand what makes a healthy community and to provide them with opportunities to engage in not only the enumerations, but the dialogue about policy. Why is this policy not working in this community? If we vote for this, why is it the wrong thing for our community to do? To bring people into a political process that not only focuses on their health, but focuses on the context in which we're experiencing health. So part of that is, in addition to the formal education that we've talked about so much at this meeting, an education in ways in which we as women can contribute to shaping the context of our lives, not only our own, but those of all women in our community.
Okay, it's your turn. We've got many minutes left. Questions, comments, visions, and if you have some on cards, we will take a look at those. Thank you. Okay, so that we're going to prefer to do it this way, it looks like. Are there some creative ways to integrate health services, information, and preventive health services with such community programs as mural painting, community gardens, and housing? Anybody? Estelle?
You know, the whole key to the Obama administration, and indeed I believe to the Rendell administration that I've been part of, is integration. Is how do we begin to think through how do we bring all of these together? When much of my focus is on behavioral health, I would often tell folks that you can't carve the brain out and deal with it separately. It's really part of the body. You can't carve out one part of our society without affecting other parts. So having worked with Jane so many years, mural arts filled a gap in so many of our communities. It really met a lifeline to making that community hostile sometimes to having them learn to work together and be together. It brought together large numbers of people to talk, how to communicate, how to gather. And I think the challenge for all of us is, where are those opportunities? Those opportunities in reality lie in being close to the community. We won't find them in universities. We won't find them in government. We find them on the street. And it's how we bring people together to take advantage of listening. The whole concept behind open government isn't the government giving information, making access to information, which is important. It's hearing from you about what information do you want. And what format can we put it in that'll be useful to you? But it's all about, how do we integrate? How do we tear down the silos? How do we not talk about tearing down the silos? How do we tear down the silos and actually getting all of these interactions to go? They really all match up, because we're talking about people, we're talking about communities, and we're talking about vision.
Great. Anybody else want to add to that? Or I'll go to the next question, which...
I would just make a comment. I think for the government to react to the need has to have some movement in the field, in the basis. So what I see is that the stimulus to this movement in the community, the leadership into the community, and programs that help to make it rise are important. As I mentioned in the beginning, in diverse age groups is necessary, diverse groups of not age or gender, etc. So how to stimulate to have more of this movement into the bases and filling the gaps, finding the opportunities. In some situations will be the mirrors, in order will be health, the topic, or housing, or children's problem in the school. So picking from what's going on there and making this fact as the stimulus, think what is really motivating for the community to go forward and take advantage of that. And then, of course, you have to have governance that have, ears open to see what's going on, eyes and etc., feelings to react to the community. So I think our role, if we want to be activists in any field, is really to sit down very close, listen carefully, and then see what are the gems around that can be, you know, stimulated to create much more opportunities.
I'm going to comment that if this open government concept, if people really feel they're being heard, if there's a sense that it makes a difference, I think it will change everything. Because there is this sense of the government is over here, and everybody's mad at the government all the time anyway these days. So, you know, to make it consumer-oriented friendly will be an enormous challenge, but could have enormous impact. All right, I'm going to read the next question and ask Dr. Woods to comment on this. You speak of the doctor-nurse impact on the health of the future. Where do you see the nurse practitioner being used to fill the gap in access to care?
I am happy to speak about that from where I sit in Washington State. We're a very rural state. Once one gets 15 minutes in either direction of the city of Seattle, we are by definition in rural counties. In the 1970s, public health nurses in our state were often the only source of health care. And the history would tell us that those public health nurses were practicing just teetering on the brink of being beyond their scope of practice. And so the universities partnered with the communities to create what became early certification programs to prepare nurse practitioners. Over the course of now some 3.5 decades, we have moved that education into graduate programs, and most recently with the development of the Doctor of Nursing Practice program. That has come about because what we have seen is the unrelenting drive to recruit nurse practitioners as well as physician's assistants, who now provide about 1/3 of our rural health care, and probably close to that in many of the inner city areas. We've needed to provide stronger education. So we've also seen our physician assistance programs move into graduate programs from undergraduate programs because of the demand for not only increased knowledge about clinical phenomena, but increased ability to interpret the evidence that now exists to inform how we practice and care for people, as well as understanding policy. So, you know, what are the dynamics around Medicaid, Medicare, and other funding sources that drive how we can care for people? I believe that in my state, so looking at where I live in this part of in this country, I believe that in order for my state to meet the increasing demand for primary health care, we will need to continue to grow the programs that provide many different kinds of health care. And I want to say that isn't going to be enough. The advance of the nurse practitioners program, that will not be enough. We cannot educate enough physicians in my region of the country. We cannot educate enough nurse practitioners soon enough. We are going to need to be very clever about how we engage people as community health workers in linkages with us to deliver services and to deliver them in different ways. We now do a lot of telehealth care in my part of the country in what we call the WWAMI region, which is a huge landmass with sometimes very, very sparsely populated areas, but nonetheless where people live who need health care. So we are going to have to become more and more clever. We are going to have to better equip our population, and here health literacy is a challenge. We're going to have to equip the population to understand best self-care practices. We are going to have to continue to educate more health professionals and educate them better, not less well or more quickly. And we are going to have to expand our thinking about who is a healthcare provider and think about ways of engaging them more deeply, and not just as community volunteers, but as people who are agents within their own communities for the health of that community. And that is going to look very different than our current formal healthcare education system. I agree with the Brazilian experience of bringing people into the communities. I think delivering services where people live, so using the housing as housing units as a locus of healthcare will also be very important.
There's a question for me, and I'm delighted to have a chance to answer it because it sort of relates to this whole notion of medical schools, nursing schools, you know, the sort of all the different ways, and of course the School of Public Health, which we have at Drexel too. But this question is very specific. It asks if Drexel University College of Medicine's Institute for Women's Health and Leadership is an institute housed in the College of Medicine, but for all interdisciplinary women leaders, or is it strictly for medical students and physicians? The former is absolutely the case. Our institute was grandmothered into the medical school. All other institutes at Drexel University are under the university, under the provost's office. But because we, among many other responsibilities and mandates, we are the guardian of the legacy of Women's Medical College, and we house the archives on women in medicine and homeopathy. We are part of the College of Medicine, but we work across all the colleges and schools at the university. And we work with other schools, and as you can see, we have an annual sex and gender research forum, which brings in all people who are doing research on sex and gender differences from the business school, from the arts and sciences, from various parts of the university, education. And so our goal is really to look at how we can improve gender issues, and in particular, how we can eliminate gender inequality. And that goes back to what Vision 2020 is about. Our modest goal is to eliminate gender inequality, and that's why the tagline is equality in sight. And at the American Conversation about Women in Leadership, we will have 8 categories, 8 topics, which include everything from philanthropy, faith, and voluntarism, that's one, to communications and media, which is critical to everything we're talking about, to business, law, and finance, to health, which obviously stands alone and encompasses all of the topics we're covering, science, engineering, and technology. The issue of women in engineering is huge in terms of the same issues that we see in medicine, which is the problems of recruitment, retention, and reentry, which Dr. Pinn was talking about yesterday. So we are trying to bring people together around the issues that we care about, and particularly women who want to see changes that benefit women and want to help all women. And that's a criterion for our delegate selection, is the women that we are selecting as our national delegates have to have demonstrated their commitment to helping other women. I think that clearly applies to everybody that's in this room and to a lot of the passion that we're all espousing here. So let me just go back to some questions here. This is a question for the entire panel. Given scarce resources, what core services are essential in a health package that is accessible to all women across the lifespan? Eliana, would you take that one?
Yeah, I think education related to health with the specificities of different age frames is something that has to be in the package very intensively anyway. So put effort, not only care, but a lot on education and, you know, spread the idea of a healthy life independent of your life group, your age group. I think this is one of the important issues. At this point, as I said, with the transition, we still need, of course, the antenatal care. We have a lot of women that are getting pregnant, and it's necessary to qualify. That's another point, because like the coverage in Brazil is very high, but we have big restrictions on the quality of the antenatal care. Then there are a lot of common situations in gynecology, in reproductive health, that are important during the age from getting pregnant to the problems that come after on menopause, and they have to be faced as well. And of course, the reproduction in both sides, and this is another problem. Both sides means if you don't want to reproduce and if you want to reproduce, because there are women who want to reproduce and they have problems, and the health system, like in Brazil, is now trying to see how to work on this area, because it can be a very important social problem for this family. So I think the package has to include, of course, things related to the reproduction in both sides, has to include the care for pregnant women, and has to include a lot of what we see with the difference of this long second adolescent, as I say, okay? I used to say I'm going to my 50s this year, so I say that I am in half of my life. So I'm starting the second adolescence because my family used to live till 90-something. So I'm expected to be around for 40 years. Yeah. So all the different situations and needs at this age, I think, have to be included in this package. And just one comment. Gynecologists, obstetricians, they are very close to women's health, but they have to be more close to women's needs. So we have been talking about that. Yes, with my counterparts in US, and it's our dream that we can change, and of course there's a lot of difficulties on that, but we do hope to be a group of professionals that care for women's needs more than women's health.
I can't resist the temptation to ask you, when you talk about reproductive health on both sides, fertility issues, and we have not really talked about the right to terminate a pregnancy. Yeah. Do you include that in your...
Yes.
Yes, okay, because that, that it seems to me, is an elephant in the room all the time, and it's just, we can't keep dodging the topic.
The tail is there.
You're seeing the tail, right?
Fundamental to women's human rights.
Yes, it is fundamental.
Introduce one of the topics I don't think got enough debate in some of the healthcare discussions is the need in the basic package for behavioral health.
Yes. Good.
I think it expands the entire lifespan, and not having a focus on opportunities both for mental health, both for mental illness and to maintain good health, and for drug and alcohol alternatives for folks. It's a subject that I sometimes don't think gets enough attention, and of course it's been a passion of mine for a long time. Yeah.
Well, and if you hadn't brought that subject up, I would have, because I'm sitting here thinking about the prevalence of depression across the lifespan in women, and the unique kinds of experiences that women have with that, as well as with some of the unique kinds of experiences with substance use, and the growing understanding we're gaining now about some of the gender differences and sex differences because of differential biology. I would add to that list, and I would certainly want to reinforce everything that we've said about starting with young women. I do believe that if we're going to affect the future, the core services really need to focus on having optimal health among young girls, adolescent girls, and that unless we start there, we've lost the impetus for good health as we age. Having spent a few years working with people who are studying osteoporosis, having worked on the Women's Health Initiative study, which is fundamentally a study of aging in women in this country, I can tell you that the origins of some of the health problems that we face as older women are probably traceable to our childhood and adolescence. Peak bone mass, for example, develops at a very young age. If we've never developed it, we're not going to have it to lose as we age. So nutrition is fundamental to the health of young girls. The focus increasingly on preconception health care would seem to be luxurious, but it's not. It is absolutely essential for healthy pregnancy. It is absolutely essential for healthy development throughout the lifespan. I would also reinforce the need for the full range of reproductive services for young women, including education, health education, about their sexuality, about their ways of controlling reproduction, about their ways of asserting their choice as fundamental to a core package of services, not something that we do in another clinic that fragments women's health care. So in summary, what I would say is I would target services to the young, to the vulnerable in the population, with the notion that unless or until we are creating optimal health in that part of our population, we have little hope for what will happen over the rest of the lifespan. And I would also argue for the integration of those services in a primary care, but probably better than that, a primary health care model, again, deeply grounded in the community, grounded in those particular populations and localities for women in the places where they're living their lives.
I'm going to read one comment. There was one comment that was made, and then we'll wrap up because I don't want to go over the time, but I'm going to ask each of the panelists in 30 seconds to leave you with the most important message they would like to leave you with. And I know my assignment was to ask for an actionable idea, something that people can take back to wherever they're returning to and do. So I will leave it to you whether you want to make it your vision for 2020 or a prescription or what you've heard. But let me just read this comment because it seems very appropriate. This person says, "It's been a great morning of community activists, and it makes me proud that we've elected a community activist as president." So there. All right, so I'm going to ask Eliana Amaral if you will leave us with a message, whatever it is, and then we'll go right down the line.
Well, I think I will go with the vision, and my vision for 2020 is that we can have an effort that intersectorial, multidisciplinary, and everybody together thinking on the needs that have been planned before, because in 2020 we have to be planning now. So what means that in 2020 I hope that we can be together working as a group, not professionals separated in their fields, because it's what happened mostly of the time now. And at that point, we can really reach all the range of health needs of women and families in general, and including men, because reproductive health does have a lot to do with that, and we don't put in the essence. I will make just one comment on the abortion, if you give me the permission. We really didn't touch that, and it's a sensitive issue in Brazil. We have a limited access to that, but there is a feeling of how dangerous it is to discuss abortion, to have a retrocess even in Brazil. So I recently participated in a discussion in Brazil with the level of the Secretariat of Women's Policies for Women, and this is really very, very important to understand. And so my other vision will be that these difficult issues could be discussed from all levels, growing from the ground in a way that we don't feel uncomfortable to talk about that in a place like, in a situation or a meeting like that.
That's great.
Having been at many levels of government, the key, I think, often is moving from vision to operations. And indeed, what we have in Washington right now is a president who's invested in the change to move from vision to operations. And my sort of homework assignment or the action step would be probably everyone is part of a group. Whether it's your church, whether it's a neighborhood group, whether it's a community group, whether it's a PTA, is to go back to the groups that you are a part of already and begin to talk about how does this community come together to set some goals and to reach those goals. Action happens in communities. University schools are catalysts for that. But the energy comes from a community. Here in Philadelphia, where we have seen people tackle crime, we see it go down. Where people tackle, I need childcare in their community, it gets built up. Where people begin to address a community issue, set a goal, and use government as one of the tools to get there, things happen differently. So the key factor is gather that group, talk to them. Where do we want to be in 2020? And what are the steps that are going to help us get there? Vision by itself is a dream. Action attacked with vision means that we move. This president, I think, this governor, this mayor are all about movement. But movement comes when those of us who live in those communities take responsibility for making it happen.
Bravo. I'm going to give you two short slogans. One is healthy girls, healthy women, healthy communities, healthy planet. And the second is, if you're not uncomfortable, what you're doing probably doesn't matter. And those will be two of the messages that I plan to take home with me. I plan to stay uncomfortable, but I also plan to use that discomfort that was generated, I wouldn't say generated here, but certainly made more acute during this meeting, to think about the healthy girls to healthy planet, and both the policies and the healthcare changes that can contribute to those.
That is a wonderful way to wrap this up, and I want to say an enormous thank you to Dr. Eliana Amaral, to Estelle Richman, to Dr. Nancy Woods, and to all of you for being engaged and visionary. I think we will change the world. That is my belief. Thanks a lot.